to kind of understand what we need to know walking into fellowship and early career.
Thanks, Amit. I appreciate the opportunity to speak with the resident fellow section for the SIR. As Amit mentioned to you all, I'm the current chairman of economics for the SIR. I'm also the advisor for the RUC for the SIR, as also the RUC practice expense representative for the SIR. And I'm going to try to give you a little bit of a background into coding and billing, and what I was actually asked to do was kind of what things are important to be putting in reports to be able to capture proper billing and coding and optimize that. This is a very introductory talk. Any of these coding topics can have webinars on their own, and I'd be happy to do some of those in the future for you all if there's an interest. But for instance, there are many nuances about coding for lower extremity revascularization or embolization coding, and what's the appropriate codes to use and code sets to use. So I'm not going to be going into a lot of detail about that, but I want to give you kind of an overview of a way to approach these things. So first of all, let's talk about a history of how procedure coding began. Prior to 1992, those were the golden age of medicine. Basically, physicians were paid based upon their charges. The more you charge, the more you got paid. So guess what happened? Physicians used to start charging a whole lot more for the same procedure, and they got paid a whole lot more. That's why you'll see typically charge masters 4 or 5 times Medicare allowable. It's a throwback to those days. But in 1992, the federal government established a standardized physician payment schedule called the Resource-Based Relative Value Scale. And in order to come up with these resource-based values, a CPT committee was formed, which is a volunteer committee from the AMA that advises CMS, and it develops codes with descriptors and clinical vignettes, and will assign a category to them, Category 1, Category 2, Category 3, where they are either well-established or experimental. Surprisingly, CMS does not pay for this, and it's a completely, as I said, volunteer committee. Why does the AMA do this? The AMA does it because they own the CPT codes and the copyrights to them, and they make a fair amount of money based upon the use of these CPT codes throughout the medical community. Why do specialty societies get involved? Because if you're not at the party, you're not going to be able to have input into what goes on. So CPT comes up with things like this. This is the CPT code 37227, which is for SFA and popliteal atherectomy, angioplasty, and stent. You'll see here there's a long descriptor, which is what you'll find in the CPT code book when you look at it, as well as a clinical vignette. The vignette is important because this is supposed to be what a typical patient undergoing this procedure is. And we use that vignette when these codes get sent back to the RUC. So CPT makes a code, and the RUC is the body which is supposed to value the code. And what happens is the vignette gets sent out in survey form to various specialty societies who have expressed an interest in the code, and they survey their membership. And based upon the results of the survey, recommendations as to what the value of the code in RVUs should be. The RUC committee is a 31-member committee of the AMA. You can see the major medical societies are participants in this, and they basically sit around a large table, and specialty societies, such as representatives such as myself, will come to the front of the table and have to make presentations to the RUC committee about what we think the value of a code should be. And this is not a very pleasant experience because basically the entire RUC committee is there to try to decrease your reimbursements because it's a zero-sum game. If you make more money doing something, somebody else makes less money doing something else. So the RUC reviews the presentations and recommendations from specialty societies. In order to be able to actually have a seat as a specialty society to make recommendations to the RUC, the society has to have a certain amount of AMA membership. to be able to get an advisor's position. Again, the RUC only makes recommendations to CMS, and then CMS will make the final decision. In the past, essentially whatever the RUC recommended, CMS would agree to. However, in these days where the budgets are shrinking, CMS is now ratcheting down and not even approving what the RUC sends to them and ratcheting these numbers down even further. So what did all of this beget? Essentially where this all started out is what's called component coding, which is a very granular system where you code for everything you do. So you have to, excuse me, code for the catheter position. Is it a first order, second order, third order? So are you in the superficial femoral artery, or are you in the external iliac artery or the common iliac artery, first order, second order, third order? And then you also code for a procedure code. Did you do an angiogram in that area? Did you also do a stent? Did you angioplasty? Did you do an atherectomy? And in the past, you would code for the catheterization, you would code for the angiography, you would put a code in for angioplasty, you would put a code in for stent, you would put a code in for atherectomy, and oh, by the way, there was also radiologic supervision and interpretation numbers. Those are the 70,000 codes that are associated with all the procedure codes. Unfortunately, CMS looked at this after some time and felt that component coding really allowed duplication of payment for services that overlap. What do I mean by that? So if you have 3 codes, for instance, angioplasty, stent, and angiography, all of which are standalone codes, all of which went in the evaluation process, you said, oh, we have to do informed consent for the patient. So they're paying for informed consent for the angioplasty, informed consent for the stent, informed consent for the angiogram, angioplasty, and stenting. So now if you go back and you look at this from CMS's perspective, they're saying, you don't do 3 separate consents, you do 1 consent for all 3 procedures. Why are we paying you to consent this patient 3 times? So they have basically charged the specialty societies to bundle everything, which is the opposite of component coding. Everything gets bundled in together. And the RUC basically assigns the codes to work on and the timelines in which those need to be done, and the codes all have to be brought back. And remember, CMS views bundling as a cost-saving activity. So 1 and 1 and 1 do not equal 3. 1 and 1 and 1 may equal 1.2. And the RUC uses several screens to determine which of these codes are going to come back for evaluation. Harvard time is something that we can talk about a little bit in future meetings, or if a code is being used a lot or codes are frequently billed together. So essentially, if you've got an angioplasty code for physician work, 35474, and you've got a S&I code, 692, that are billed together all the time, they'll say, why do we need 2 separate codes for that? Let's get only 1 code to express that. So if you look at peripheral endovascular intervention, peripheral arterial lower extremity revascularization, let's take 1 code, for instance, 37226, which is angioplasty and stenting in the superficial femoral / popliteal artery territory. Previously, before 2011, that procedure, angioplasty and stenting in the superficial femoral artery, was reported with 35474, which was angioplasty, the selective cath code for placing the catheter into the superficial femoral artery, 36247, the stent code, which was 37205, and then the radiologic supervision and interpretation for each, 75962, 75960, and 716 and 75625, which is the S&I for aortography and a runoff angiogram. Now, no longer do we report all of those 7 codes. We report a single code which captures those 7 codes. And guess what happened? In pre-2011, if you were doing these things in the hospital, as we all do, you got paid roughly $1,000 to do an angioplasty and stent in the superficial femoral artery. Now you get paid roughly $685. You see that bundling is, by CMS's standards, a cost savings. I guess if we're the people that this is happening to, we don't necessarily view it as a cost savings. We may view it as something else that's happening to us. So what do you do? What's the best way for you all to prepare to understand coding and to try to generate reports that capture appropriate codes? What I would do is, in your practice, wherever you're working, identify the top 10 or 15 procedures that you do. So for instance, lower extremity endovascular intervention, embolization codes, AV dialysis, fistula work, venous access, etc. Whatever those procedures may be that you're doing, identify those. And then go to the CPT book. You'll have them in your facilities. Just pick up one of the CPT books and read the sections about those codes. There's a lot of introductory language, and this is just a page out of the CPT book, which talks about endovascular revascularization, open or percutaneous. And it talks about the family of codes and how the territories are divided up. And then it will talk about how to specifically use these codes in billing circumstances. And this will give you the background on how to successfully code for these procedures and appropriately code for the procedures. Once you know how you're supposed to be coding for the procedures, it will tell you what you need to do in your reports. So what do you need to do when you're dictating a report? Dictate everything as if it is component coding. It doesn't matter if it's bundled or not. You should be dictating these things as if they're component coding. You are going to specify where every catheter tip is with every injection. You're going to specify every type of intervention you do. If you do an angioplasty, if you do a thrombectomy, if you do an atherectomy, if you do a mechanical thrombolysis or a chemical thrombolysis, you want to be telling the reader of that report every single thing that you are doing. And there should be detail revolving around all of the steps that you have taken. Essentially, I'd like to be able to close my eyes and listen to the report being read to me and be able to visualize every single thing that is done. That is what an effective report is. Look at, when you're in your facilities and you're looking at your electronic medical records, see if there's any operative notes that you can look at. Surgeons do a tremendous job in dictating their operative reports, and they will talk about how, the skin is incised, and then the subcutaneous tissues are explored, and the fascia is exposed, and the fascia is incised, and how retractors are placed, and what care is taken with all of these, and when they're placing sutures, what they're doing with the sutures, and what they're tying off. That level of detail is important for a number of reasons. One, medical legally, but two, it shows that you're doing a lot of work, because what we do are fairly complex procedures. And if you, in a report, basically say, we put in an IBC filter, everybody thinks it's easy to do. And therefore, it's probably not worth much to do it. But when you start to understand how difficult some of these are, and people reading these reports see that it's difficult, it adds value to what you do, and it helps justify the payments that you receive for doing it. I personally will title my report as if I were coding just off the title of the report. So for instance, if I were to say I'm doing a fiber embolization, I would title the report bilateral uterine artery embolization with bilateral selective catheterization of the uterine arteries and hypogastric nerve block with ultrasound guided access. And therefore, when I'm reading the title of the report, I know what codes need to be put in. Now, certainly I don't think any of you are going to be at that level to understand all the nuances of coding to know what you need to put in the title, but if that's what your goal is, then you can get there. If you never think about those things, then you'll never get to the goal. You do need to include in your reports standard dictations regarding conscious sedation, and you also need to have standard reports regarding ultrasound guidance. So for instance, with conscious sedation, continuous EKG monitoring, pulse oximetry, and blood pressure monitoring is performed by an independent trained observer. 15 minutes of sedation time was utilized and the patient received 50 micrograms of fentanyl and 1 milligram of Versed. those sort of things need to be put into your reports. If you do ultrasound guidance, you have to specify that real-time ultrasound was used to identify the right internal jugular vein. It was demonstrated to be patent. Images restored for permanent record. Under direct ultrasound observation, the internal jugular vein was accessed. A micropuncture catheter was inserted, and so on and so on and so on. So you should develop some standard templates that you're going to use. When you're going to be doing coding after you've done your reports, one resource that you all should use is the SIR coding worksheets. All of you at your institutions are going to have either yourselves being members of the SIR, or many of your staff members will be members of the SIR. And as members, you actually have access to the SIR coding guide and the worksheets which are in the back of the coding guide. And try to code all of your own reports. After you're coding your reports, also develop templates. If you're doing something that's fairly common and you do it the same way each time, develop a template report. So if you're putting in PICC lines, 90% of the time you do a PICC line the same way. So you might want to have a template for that. Standardized reports are something that are being developed as an initiative with the SIR. I'm going to talk a little bit more about those in a little bit, but essentially these are templates that are designed to be used at a national level. These are some of the SIR coding sheets. I'm not going to go through these in great detail, but basically you have your first, second, and third order catheterizations, and then you have the different procedures that are associated with them, angioplasty at different levels. And you can see for all of the different areas, there's one on breast. This is for MRA and CTA. This is for central venous access. Again, here's lower extremity revascularization, myelography, and pain management type procedures, and so on and so forth. You can see, and they even have these for evaluation and management services, and biopsies, drainages, and venous interventions, thrombectomies, and here's for endovenous laser and closure procedures. So the coding worksheets that are out there are going to help you really understand and take some of the imposing nature of that large CPT book out of the way, because it's really focusing down to the codes that IR uses. Typical reports will generally be, as you do for most of your diagnostic work, a title with the procedure performed, history. It's going to be very important for you all to include a pertinent history in your reports, because as ICD-10 comes along, all of the insurance carriers as well as Medicare want to see a appropriate ICD-10 code, which is the diagnosis code, that supports the procedure codes that are being reported. So giving the pertinent clinical history in your report is going to help your coders make sure that they're able to justify the procedures that are being done. The body of the report needs to have a statement that you performed informed consent, and in that paragraph or sentence about informed consent, you're probably going to want to list the major complications that you've discussed with the family and the family or patient have agreed to. You're prepping and draping the patient. What is your mode of access? Did you use any ultrasound guidance or any other type of guidance? Fluoroscopic guidance and so forth. Conscious sedation we talked about. And then again, procedures with details justifying the level of selectivity that you've performed. And also try to sometimes use layman's terms. It's funny, I review all of my coding. All gets sent off to our certified coder, and then the coding comes back to me to double check it before we send out our bills to submit our bills to the insurance companies. And I noticed sometimes that they were not billing for the angiogram. And I went to our coder and I said, why aren't you billing for the angiogram? And they said, well, you don't say anywhere in the report that you did an angiogram. I said, well, right here, I said the catheter was in, the external iliac artery, and contrast material was injected, demonstrating a stenosis within the iliac artery. I said, that's an angiogram. She said, well, you never said it's an angiogram. So what you may take for granted, other people may not actually have a level of sophistication to understand those nuances. Remember, coders are not physicians. They're individuals who have taken coding training courses and understand some of the anatomy, but may not understand some of the other nuances. Getting back to the typical report components, after you talk about the procedure, how did you terminate the procedure? Did you use a closure device, or did you just hold pressure? Obviously an impression, and then you're going to give a fluoro time or radiation dose equivalent in the bottom of the report as part of our whole PQRS. What are standardized reports? Standardized reports are essentially report templates, and the SIR is using these as a method of fueling registries. So if we have a standardized report and everybody is using this standard report, when those reports come back electronically, you can pull specific data fields out and fill registries. And government agencies are now wanting to see in registries outcomes data for PQRS. And again, if you have these standardized reports, it'll allow automatic PQRS participation and also benchmarking. The SIR is going to be starting these with procedure reports. I'm going to show you some examples of that. But then again, expand this to follow-up notes and visits to obtain real outcomes data at, let's say, 1 month, 3 months, 6 months. Right now, kyphoplasty and vertebroplasty are undergoing a lot of scrutiny because of some of the reports that had come out in the New England Journal of Medicine talking about sham procedures versus kyphoplasty, even though there's a large body of literature that shows that kyphoplasty is effective. There was some doubt cast upon that, and now agencies are looking for justification that when they're paying for vertebral augmentation, they're paying for something that's worthwhile. So getting back to these standardized reports, there are 5 procedures that currently have standardized reports which are almost ready for prime time. I think they're going to be released soon. I don't have the exact date yet, but IVC filter removal, IVC filter insertion, uterine artery embolization, central venous access, and vertebral augmentation are the 5 procedures right now that are going to have standardized reports. Now this is actually an example of a standardized report, and I excuse the length of this because in a Word format or in a slide format, there's a lot of verbiage which actually is just in a drop-down menu. So it's very compact in the report, and you would go through an electronic drop-down menu and pick and choose to fill the fields. That's how the standardized report would be looking. So again, here, indication for the procedure, these are going to be in a drop-down menu. The procedure performed, the access method, venous imaging, image guidance, again, these are all in drop-down menus, but here they're all kind of laid out here in a Word format for you to see. Findings, and then the venographic findings, and it just goes on, summary of the procedure, summary statements, plan of procedure, and again, here's the informed consent, timeout for the procedure, the anesthesia, the medications that were used. So you can see much of the things that we've talked about have been incorporated into these standardized reports, but that will make your life a whole lot easier when they're introduced to your facilities. And I would think that actually most training centers are going to adopt these and use them for most of their procedures. So you'll be seeing that come across. So in conclusion, what you need to familiarize yourself with CPT codes, and I would familiarize yourself with those that are associated with your most common procedures. Develop templates and be aware that standardized reports are going to be available in the future, and be as detailed and specific in your reports as you can be. You're spending a lot of time doing these procedures, and you want to show people what you did. And remember, if you don't dictate it, you didn't do it. So you can do a ton of things, but if you don't put it in your report, it looks like you never did it, and you can't bill for it. So I'd be happy to answer any questions that may have arisen as we've talked, and I'll turn it back over to Amit.
Thank you, Dr. Niedzwiecki. That was really informative and a great introduction for us. I wanted to actually ask you, in terms of how things are going to change with ICD-10, how do you anticipate that kind of impacting the way that we have to report, or in terms of specificity, or with regard to level of detail?
All of the ICD-10 is much, much more granular than ICD-9. It's been delayed now several times in its implementation because it is going to be extremely costly for practices in general to implement and become compliant with. And some people are talking about, well, wait a minute, ICD-11 is just on the horizon. Why don't we just skip ICD-10 altogether and go to ICD-11? I don't know what the final answer is going to be regarding this, but because ICD-10 is so much more granular, you are going to have to be extremely specific in your histories that you're giving about the patients. And so you're going to need to go back into your electronic medical records and look through and really find the justifications for the procedures that are being done. And one of the things that will be important for you to do is to get friendly with the coder for the practice, whether it's a hospital coder or if the group has their own coder. And they'll generally generate cheat sheets about, for specific procedures, what are the codes and diagnoses that are acceptable to support these. And you'll have to kind of try to find justification for those things. And again, most of these things are, unfortunately, you have to go through it and you have to live it a little bit. There's no one thing that you can specifically say that, you know, doing this level or that level of justification is going to, across the board, guarantee payment.
Got it. And in terms of how things are changing, obviously with the Affordable Care Act and the formation of ACOs, do you think that there's going to be different, like, you know, obviously I think ICD-9 right now is the standard by which most health insurance companies, Medicare, et cetera, evaluate and code. Do you think that there's going to be different standards down the road with the Affordable Care Act, or that everyone is kind of just going to stay on the same page?
I think everybody will wind up transitioning at the same time. If ICD-10 is going to be implemented, it'll be implemented across the board. Some private payers are lagging a little bit behind and might stay with ICD-9 for a slightly longer time frame, but as this has been delayed, more and more of them have caught up, and I think the likelihood of there being stragglers are less and less. The interesting thing that's occurring right now with the Affordable Care Act is you may have heard about alternative payment models, and you also mentioned the ACOs. Alternative payment models are, is there a way to pay for caring for a patient without fee for service? So is there a way for a patient to be have one payment to care for a patient with pneumonia and pay everybody out of that, as opposed to, you know, I'm going to pay the intensivist, I'm going to pay the pulmonologist, I'm going to pay the primary care doctor, I'm going to pay the hospital, and so on and so forth. So there's these alternative payment models. One of the questions that's been floated just recently is, are there alternative payment models for specialty societies or specialties? So in interventional radiology, is there some other alternative payment model that will work as opposed to just fee for service? And the society is now kind of trying to explore that and determine if there's any disease processes that would lend themselves to episode of care payment. It's a difficult question. It's a difficult question.
Does anyone else have any other questions?
There's a couple of questions in the panel that I'll ask that are coming in. I'll go ahead and ask them. Brandon Alvieri, he's asking, do you know if any other specialties are currently using standardized reports, for example, cardiology for peripheral artery or catheterizations?
There are actually many of the society, I would say several societies are ahead of us as far as standardized reports go, and cardiology is one. They do use standardized reports. I don't know the exact procedures that they are using standardized reports for, but they do have registries and standardized reports.
We have another question from Alex Covington. He's asking, when will IA, interventional radiology, be on the specialty panel that meets with the RUC?
So the RUC has 30 some odd members to it. There is the American College of Radiology has a seat on the RUC panel, and the Society of Vascular Surgery had a rotating seat that opens up periodically. The rotating seat would be the only seat that the SIR would be eligible to participate in, but that is a seat that generally speaking is sought after highly by multiple other societies. The SIR is large enough to have some sway, but sometimes does not have the respect to allow them a seat on the RUC. We already have advisory positions. As I mentioned, I'm the advisor for the RUC from the SIR. So we already have a position, an advisory position to the RUC, and most specialty societies have advisory positions. And even the ACR, even though they have a seat at the RUC, have a advisor position also. And when there is a diagnostic radiology code that comes in front of the RUC, the RUC advisor, his name is Zeke Silva, does the presentation to the RUC, and the RUC representative from the ACR is silenced and cannot vote and cannot have input into RUC process. So it's a very tightly controlled system with an effort to minimize any bias that might leak in.
As an add-on, does the fact that that IR ACGME is representing IR as its own unique specialty have any say, or do you think that could hurt as far as having advisory roles with the ACR seat?
No. No, in fact, I think it's very healthy that that interventional radiology is now recognized as a separate subspecialty. I think it only is going to allow the perception of IR to grow. When I first started going to the RUC multiple years ago, myself and Sean Tutton, we used to get beat up all the time from especially the surgeons when we would talk about rounding on patients and seeing the patients. You know, they'd say, you guys never round. You don't see patients. You don't do clinical work. And we had to, you know, essentially bring them to the side and in public debate with them the fact that we are a clinical specialty and we do take care of patients. And that perception has changed as time has gone on. But early on, we were viewed as technicians, not as physicians.
Dr. Niedzwiecki, we have another question regarding in-stent restenosis. The question is, have you come across reimbursement challenges pertaining to in-stent restenosis? For example, I guess the analogy is non-payment for readmission with CHF within 30 days for cardiology.
We have not had that issue occur for in-stent restenosis, specifically because the global day period associated with lower extremity revascularization, I believe, is a 0-day global period, and it has not come onto the radar screen as being a significant cost to the system in general. So, for instance, readmissions for congestive heart failure cost the system a lot of money, and so therefore the system says we're not going to pay for it because you shouldn't have readmissions. And so that's Tom Scully, who used to be a former head of CMS under Bush. I had the pleasure of having lunch with him at a SIR meeting. He said, you know, it's pretty simple. CMS, the way CMS acts, the game whack-a-mole, Chuck E. Cheese, when the mole sticks its head up, you know, you whack it to push it back down. If something's costing a lot of money and it gets up onto the radar screen, the mole sticks its head up, CMS whacks it. So when things are costing them a lot of money, then you see some response to it.
Thank you. I don't think we have, actually, I'm sorry, I think we do have one more question. Is there a movement to work collegially with other specialties to develop quality outcome measures, working, for example, with the Society for Vascular Surgery to develop definite outcome measures for reimbursement for CLI?
So we work very closely with the Society of Vascular Surgery as well as with the cardiology societies to try to ensure that the voice of SIR and interventional radiology is heard and well represented. You know, we obviously want to be collegial and work along with these societies, and at the same time represent our membership. So it's a fine line and a dance that we try to orchestrate well to be able to serve our membership so that they're well represented. Sometimes it can be a little challenging, and one of the things that you have to remember is that right now, if you look at the Medicare database and who are the prime providers of lower extremity revascularization, cardiology is the dominant provider for that, followed by vascular surgery, and IR is third. Nobody is doing more than 50%, but each of those societies are doing a little bit more than SIR. And what happens when Medicare is looking and taking notice on this, they look at the dominant specialty for the lead, if you will, on what's happening. So we have to work alongside and along with the other specialty societies.
Got it. Thank you. Is there any recent data on IR market share for PVI?
For peripheral vascular intervention?
Yes, I believe that's the question.
The only database that's published is the Medicare database, and so it is, as I mentioned to you, cardiology is the dominant provider, and followed by vascular surgery, then by IR. I believe I hesitate to actually give a number. You know, we're probably in the mid-20s to high 20% as a provider goes in peripheral intervention. So we're not at 5%, as some people had thought for a long time that we were losing PVI in droves. But what happens is sometimes there are some interventional radiologists in private practice who, because their partners are saying to them, you know, you need to read films, you need to read films, stop, you know, playing around with those patients, stop rounding on the patients on the floors, they start to lose some of the peripheral interventional patients because they're not taking care of the patients. They don't have a clinical practice. And then they don't wind up trying to regain that lost ground. And then it makes it hard sometimes when newer, younger IRs come out to regain that ground. But I encourage you all to do that. I have a very, very good peripheral interventional practice, and it's been a lot of work to maintain it and to grow it. But it's worthwhile doing it. They're very rewarding cases.
Great. I don't think we have any other questions. And if anyone does, please send a quick message to the question box. But if not, Dr. Niedzwiecki, thank you so much for taking the time to give us this webinar and kind of talk about bullying and coding. On behalf of everyone in the residents and fellows section, thank you again, and we really appreciate it. This was a great introduction for us, and we hope to have you again as a speaker to kind of expand upon this topic and learn more.
Yeah, I'd be happy to. And again, if you guys have specific coding areas, for instance, if you wanted to talk more about embolization procedures and the specifics in coding there, or peripheral interventional procedures and the specific coding in those areas, be happy to go through all of that with you all. Again, just wanted to give you more of a general overview of this whole process and where to go, because there are, I know, some practices that don't do a lot of peripheral intervention. They do a lot of dialysis, but there are other practices that don't do much dialysis, and they do more central venous access and so on and so forth. So it's kind of hard to do an exhaustive discussion, especially in 1 hour, that's going to serve everybody's purposes. So.
But thank you again, and I don't think we have any other questions, so we'll conclude here. And thank you, Dr. Niedzwiecki, and thank you everyone for attending this evening.
Thanks.